statins within pregnancy. Well, there are some questions about that because there are some safety studies that probably it could be performed, but it's still not the way to go. But bile acids are, I think, the most used and safe drugs to lower cholesterol. And of course, we know that during pregnancy you have a high cholesterol stage. So you only need to do that if there is like familiar hypercholesterolemia with a really high risk. So otherwise, I wouldn't really treat a high cholesterol during pregnancy.
Okay, that's really helpful. And again, Carlotta, should experts in maternal-fetal medicine be performing echocardiography on these patients?
Sorry?
Do you think we should, maternal-fetal medicine specialists should be doing echoes on this woman?
Well, we have a fantastic one, Dr. Jérôme Cornet in Rotterdam, who does that. And it's sometimes helpful when a patient is really in a severe situation and he sends us the pictures or the tapes. But well, if you really have an interest in that or for research intentions, I think it wouldn't be so hard for obstetricians to learn. But well, the nuance in assessing cardiovascular function is really based on experience, and I think we need to collaborate to share each other's experience, but we don't need to take over each other's expertise. I think.
Correct. As if the fact that we have so much time that we have plenty of time that we can go around and do echoes on our pregnant women.
Maybe AI is going to help for a basic screening, you know, and if you have an AI tool that an obstetrician can do that, and it's screening based, and then of course if it's abnormal, goes to a cardiologist. Maybe
that might be a good approach. Yeah. Fantastic. But also there is some really simple methods that you can do simple cardiac, like cardiac output, for example, and systemic vascular resistance, which does really need a lot of training and very, very simple. We published a lot of data on that, and Jerome as well published on that. So I'm just conscious of the time, and we still have many questions, but I'm just going to pick up a couple of questions because I'm conscious we don't want to exceed 2 hours. And we're already more than 2 hours. So Letta, again, your question about the NICE guideline and the women sort of have future cardiovascular risk. And actually, if you read the NICE guideline, it does highlight that women who do develop preeclampsia or gestational hypertension need to be counseled about their future risk. And in fact, they have a table where they give you the estimates of this increased risk. And of course, they need to have follow-up. The precise nature of this follow-up is not, I'm not aware that's been really well defined, or there is a guideline to establish this follow-up. And I doubt so much that will be for us as obstetrician gynecologists, because it's a long-term follow-up. I suspect to be more for the general practitioners and the cardiologist or the internist. Back again about the screening, because it's often, and Fabrizio, maybe it'll be interesting to hear your view, because people will compare the NICE guideline or NICE screening versus FMF screening, which is really a bit unfair comparison, because NICE does not cover screening. NICE never really would make any recommendation about screening. What they have mentioned, these are the risk factors. In fact, if you look at the risk factors they mentioned, they didn't even include ethnicity, which is a well-known risk factor. And NICE is very clear. Screening recommendation is not within their remit. It's the National Screening Committee. And the National Screening Committee reviewed the evidence. This is what their recommendation. So I know that we commonly do that. We commonly say, well, that's a NICE guideline and that's FMF. But I think it's a really unfair comparison, because NICE never issued this as a screening. They did not say this is how you screen for them. They just mentioned the risk factors. And I don't think it was sort of reviewed in a systematic approach to say this is a comprehensive list of risk factors, or the fact that this is how we screen them, because if you screen them, each risk factor is the same. But I mean, that's just, it'd be interesting to hear your thoughts, Fabrizio.
Yeah, I agree that NICE never said that, besides you are using their history-based risk factors as a screening tool. But ACOG said that, right? ACOG very clearly is recommending to use maternal history as a screening for preeclampsia. That's similar, a little bit different, but similar with the nice risk factors. It doesn't work. It's proven that doesn't work. Of course, history is important, but it's very easy to understand because why someone that's 39 years old and 11 months is low risk, and then a few days later, when she turns 40, she became magically high risk. Someone has a BMI of 34.9 and then had a couple of pizzas over the weekend, and now the BMI is 35.1, it magically became high risk. And the other thing, it doesn't count the protective effects, right? I can have a high BMI, and I had a patient that she's an Olympian. She's a weight lifter, and she has a very high BMI because the way that she practices her sport, but she's extremely fit person. We did first trimester screening for preeclampsia, and she was extremely low risk, right? We have to use multifactorial approach because basically balancing positive and negative likelihood ratios, and then you have a risk. It's the same for ethnicity. We know that ethnicity plays a role, but you cannot basically label someone as high risk because of the ethnicity, because someone could be Black, that we know that's a risk for preeclampsia and cardiovascular disease, but is extremely healthy, and then you do the multifactorial screening, and this person actually is very, very low risk. We also can have someone that's white, but has a combination of risk factors and a bad placenta, and you'll be high risk. This is the importance of the multifactorial risk. If you don't have everything to do your risk calculation, you can do a simple risk calculation. I did that in Brazil using maternal history and mean arterial blood pressure. The prevalence of preeclampsia in Brazil is doubled in the UK, Australia. I think that we have around 3%. In Brazil, 7%. And using maternal factors and mean arterial blood pressure, but using the algorithm, the detection rate for preterm preeclampsia was 67%. And we compare with the NICE risk factors and the ACOG recommendation. And this very simple approach was far, far superior than using maternal history only. It means that even in low resource settings, you can do a better screening if you're using the algorithm with more simple combinations that is available for everybody.
Fantastic. There's so many questions, and I'm trying while you're talking, like screen through them to try to cover most of them. But I said I'm conscious of the time, and I know Fabrizio it's late evening for you in Australia. So just the last two questions, one for each one of you. So Shahinda, is there any drug or intervention that is known to be anti-remodeling? So the women who develop preeclampsia, they have this cardiac remodeling, and you showed us this beautiful data that they have almost heart failure stage 1B, or they have diastolic dysfunction. Is there any drug that can actually reverse that?
Yeah, very randomized controlled trials are with ACE inhibitors. And there is a debate whether the ACE inhibitors decondition cardiac geometry because of they lower blood pressure, or whether they really have a direct effect of like the cardiomyocytes. Like we know that ACE inhibitors in heart failure where the ejection fraction is reduced, that ACE inhibitors are capable of really having a direct effect of like a positive effect on cardiac remodeling. So in patients with a reduced ejection fraction. In our case, women with preeclampsia don't have a reduced ejection fraction. They have like a normal ejection fraction, but they have diastolic dysfunction and they have left ventricular hypertrophy. So in heart failure world, we call this HFpEF, heart failure with preserved ejection fraction. In this cluster, ACE inhibitors failed to show a positive effect on cardiac remodeling. So I have my doubts whether ACE inhibitors will have like a good effect in remodeling after preeclampsia. They will have a positive effect based on lowering blood pressure, but I doubt whether they have a direct effect on cardiac remodeling through cardiomyocytes. But we have since 2 years now a new drug that is effective for heart failure with preserved ejection fraction, which is the SGLT2 inhibitors. It's the first drug that are positive in HFpEF, and they have also a positive effect on kidney function, metabolic state, cholesterol, insulin, so have a really broad range of positive effects. All of these markers and characteristics are impaired during preeclampsia and in most cases after preeclampsia. So myself, I do believe, and that's also actually a trial that we're designing with several groups now, is that we need to look into those SGLT2 inhibitors, whether we can reverse cardiac remodeling and improve cardiometabolic states and kidney function after preeclampsia with those SGLT2 inhibitors.
Okay, I think there is someone just put another question related to that name of the drug, please. So that's the angiotensin receptor 2 inhibitor, is that right?
The soluble glucose SGLT2 inhibitors. So it's the receptor in the glomerulus that lets the glucose go away. So it's actually, it started as a diabetes drug, but it is now used as a heart failure drug. So it's the SGLT2 inhibitor.
Fantastic. This is really cutting edge, isn't it? I mean, we could spend another 2 hours talking about what.
Oh, yes, I would love to.
And definitely we invite you again, Shahend, for maybe another talk, because I think this discussion is great, and you can see still people, I mean, posting questions or comments. But as I'm conscious of the time, and I don't think it's healthy to stay in front of the computer for that long.
Mm-hmm.
But Fabricio, last question about the mechanism of aspirin, because I think that's a big question. I know that your team have done a lot of work on that. What the effect of aspirin on blood pressure, for example, or the women who have increased risk and had aspirin, are you trying to Doppler? And I'm going to try to squeeze another question in this question about the Spanish data there on the mass control trial, is that you give them aspirin, but you do a second trimester assessment and you potentially can stop the aspirin. So can you comment on all of this in maybe a few minutes?
Okay. Mechanism of aspirin, I think that's still a bit unclear. We don't know very well as aspirin works. Probably is working in multiple mechanisms. We published before that using BIVU cells. BIVU, they are trophoblast mole cells that they are basically imitating syncytial trophoblast function. In vitro aspirin, and by the way, 150 milligrams was very interesting because we were able to test different doses in vitro, and the best dose is 150 milligrams in vitro as well. We were able to improve PLGF gene expression and protein expression and decrease S-FLEET's gene expression, protein expression. Basically, there's some sort of function in trophoblast. It makes a lot of sense that this is the reason that you have to start before 16 weeks, that the time placentation is still occurring. And if I'm doing that over 20 weeks, placentation already finished the process, and then I cannot act in trophoblast function. And then there's endothelium effect of aspirin as well, and of course, working the thromboxane. Is a way to measure aspirin function, and this is a bit tricky. I'm sure that maybe Shahinda has more information about ways to test if aspirin has been effective, but we don't have very good tests. Basically, it's testing platelet function. Regarding the Spanish study, Of course, the study was well conducted. It's a strong group. But with my due respect, I don't think that makes any sense to stop aspirin. I don't think that makes any sense to do a test to check if you can stop aspirin or not. I think that the strong evidence is to continue aspirin up to 36 weeks. I'm very uneasy with the idea to stop aspirin if the profile changes when you're doing a secondary screening test.
Okay, well, thank you very much. It's another controversial area that we could spend another half an hour talking about it. But it's been almost 2.5 hours. I have to say, I really enjoyed it. I thoroughly enjoyed it. Your talks were fantastic. The discussion was great. The questions are really, really relevant. It's cutting-edge research. So thank you very much. It's a pleasure to have you both, Fabricio and Shahinda. I decided that I'm not going to give my talk. Believe me, I enjoyed your talks and the discussion. So I'm going to give my talk later in another future webinar. So thank you very much. Thank you for these amazing delegates who kept posting questions and comments. Really great to see you being very interactive with the speakers. And just again, thank the sponsor, GE, for sponsoring this webinar, and thank the team behind the scene who work really hard to make sure that these webinars are successful. Remind you, these are recorded, available free, and you should have certificate, and we will put the QR code for the feedback. Please take your time to fill it. And just really say thank you very much, and I hope you enjoy the rest of the weekend, and I will see you in another webinar. Thank you very much.
Thank you.
Thank you all.
Hours. It was only supposed to be on for an hour. Look what I've got for you. Aren't I a kind human? Hey? No.